I think we've had a really nice overview of some of the hot topics. I'd like to take about maybe 5 to 7 minutes to have a discussion with the panel now. And more importantly, from the audience as well, we'd love for you to step up and ask questions. I mean, I think that the discussion about antithrombotic therapy and contrast use may not be as sexy as how to cross undilatable lesions, but in most practices now it's very, very relevant. And so let me start by asking attender the question, do we use isoosmolar contrast in 2017, given some of the cost constraints that we all deal with? And if we do, who do we use it in?
You know, this is an interesting question, and we published one of the meta-analysis on it. And when we look at the data, I think the problem is the studies are done to favor the drug of the sponsor, right? So you design a study in a way that makes one drug look better than the other. I'm sorry if I'm sounding a little harsh, but that's the truth. So if you look at the data on iodixonol, it is clearly better than some of the low osmolar contrast media. So it is better than iohexol. I think that there is pretty good data on that. But is it better than some of the other low osmolar contrast media? We don't really know, because those studies were developed by the other companies, and the patients that took didn't really have enough of AKI that you could say with certainty is one better than the other. So I think that question still remains. In our lab, we use iopamidol. I don't want to use a trade name, but in ARIA we use a different isoosmolar contrast media. But my sense is if you're using less than 2 to 3 times your GFR, there's probably not a difference. So we did an observational study on this where we matched on the total amount of contrast a patient receives. And there, if you're using very high doses of contrast, more than 4 to 5 times your GFR, you clearly see a benefit of iodixonol. So the way we've adopted in our practice is if you run into a complication and you have to open a second bottle, well, that may be the time to think of using isoosmolar contrast media. Right. Otherwise, we only use it for carotids and legs.
So let's have a show of hands. So the isoosmolar contrasts, how many of them are there in the market? There's Visipake. Is that pretty much it? Let's have a show of hands. How many people use the isoosmolar contrast in their practice? How many? The rest of you don't, right? This is incredibly relevant for large hospital organizations. We've recently had incredible pressure from our hospital systems to look at every aspect of our practice, and this has come up, and we've, dug through the literature. We looked at, the work that Tom presented, and also your work, Tender, and it's a wash, and it's difficult to know. Let's have just a couple of words from anyone else on the panel about how you John, what is your take on it?
Yeah, I think nowadays, as interventional practice has spanned structural, peripheral, and carotid included in the coronaries, we just never know what cases we're doing. I think the chemotoxic, the separate effects of these agents for peripheral angiography, which we do a lot of, certainly favor isoosmolar. So, as opposed to changing back and forth and making case decisions, we've been able to just negotiate our contracts, work with our, not just cardiology, but interventional radiology, who uses a lot of this, and bundle our pricing across the health system. So I just think the concept of trying to pick which one's better, this is better for most people, it's better for most people, it's probably better for all people. That's my reading of the literature. And so the amount of money that it costs in the cath lab is relatively small in terms of other cost-saving things of switching from femoral to radial, for instance, would be far more cost-saving in a cath lab than the contrast.
Yeah, I think the other issue that I think we probably don't have a lot of data on is just a lot of the patients that we get through our lab get repeated doses of contrast for a variety of reasons, whether it's CT, for other non-cardiac reasons, or cardiac CTs. There are patients who have multiple procedures during the year, and it's become very difficult to quantify exactly what effect that has on the reserve renal function, primarily because our registries are largely episode-based. They're not linked across encounters. So I think that's something else that we have to keep in mind. I mean, if the patient has had 6 procedures involving contrast in the last year and you see them in clinic, their decline in renal function, should you really just ascribe it to progression of renal disease or hypertension, or is there some effect of the contrast that's been given?
I mean, I think if there were no cost issue, the combination of some of the data suggesting that isosmolar is better, and frankly, in terms of patient sort of comfort, especially when you inject limas and outside, there's no question that it's easier to use. It always comes down to a cost issue and negotiating, as most things. So on that topic, Sunil, let me ask you, who do you use BiVal in your practice? I know you mentioned it, but I want to summarize for the audience. And let's have a show of hands in the audience. Who uses BiVal in their practice? Manos? As a major CTO operator?
Well, actually for CTOs is the one you don't want to use, not only for the bleeding reversal, but also there's been cases where you have more clotting in your TUI or your guide with prolonged cases and stages of blood. So definitely for CTO, BiVal is not the way to go.
Yeah, we used to see the same thing with radiation. Remember the old days when we did a lot of radiation? Using bivalirudin, there were several case reports of thrombosis, vessel thrombosis while you were waiting for the radiation oncologist to come upstairs.
So let me ask a question with regard to unfractionated heparin. And we kind of switched out mostly to unfractionated heparin a few years ago, and I know we've been talking about this. So are there differences between different stocks of unfractionated heparin? Because that's what sort of turns people off. They get the odd case where suddenly your ACT is 120 in the middle of a complex case. And then how do you mitigate against that? What are the practices and the protocols in the cath lab? Do you check ACTs every 10 minutes, every 15 minutes? Whose role is it to remind the operators to do that? Any thoughts about that, Manish?
Yeah, so we've, I come from the bastion of bivalirudin with Greg Stone, but we've also actually switched quite a bit to unfractionated heparin here. And I think it's really, the bival is really for the high risk bleeding patient at this point that we're utilizing. We've gone more and more to radial intervention. But it's not, ACT checking is critical because I have to be honest with you, giving 80 units per kilo of heparin is no longer going to be adequate in all patients. I'm impressed how, I have to give 10, 12, 14,000 units of heparin to get a therapeutic ACT. So my rule with the fellows has become, we're not putting any stent in until I know the ACT is therapeutic. And if I have to wait, so be it. Because otherwise, that's when I think we're going to get burned. I think there is a huge cost savings. We have not seen an increased bleeding risk with complex cases. We're very careful with groin management. That has to be the tenet. But that's how we're using it.
Yeah, I love the idea, and we don't want to sound like cookie cutter practitioners, but I think more and more as we get into our cath labs, we need to be really standardized. We have the whiteboards, you come in, you write the brief history, you put the GFR, you put your contrast load, and then every 15 minutes, it's really the person in the control room's responsibility to remind people, because I know I forget in the middle of cases. So having that sort of protocol, I think, does help. Any other comments? The one other question I had with respect to contrast is, how do you use the LVDP? And do we need to be more prescriptive about that, for your patients with heart failure? Okay, so let's say your LVDP is 22 or 25, and you have someone where you've given 100 and 125 cc's of contrast, and your GFR is 60. How do you sort of individualize that? Is there any thought about how to manage that? How do you follow this patient's?
So I guess, I have basically taken the point that we don't want to put patients into pulmonary edema. And the other thing which is not commonly recognized is that venous pressure is a risk factor for contrast nephropathy. So higher your RA pressure, more likely to go into contrast-induced kidney injury. So I think in those patients, if I identify the EDP is high, I cannot hydrate the patient, so I'm more likely to switch to using biplane. And once you sort of figure out early on how much contrast you can use, it's very easy to stay below that threshold.
My approach for years has been a little bit different, and I didn't read all the trials or do all the trials, but early on I used to do a right heart on all these patients in New York. Anybody with normal kidneys is almost an exception now that we treat, and I find that doing a right heart up front, getting the wedge to where I want to, knowing the LV function and the valvular disease, and then doing a closing wedge at the end of the procedure, monitoring how much contrast you've given, appropriately hydrating up front before you give any contrast, and then hydrating appropriately afterwards has worked very well over 2 decades. It's a little bit of the same, but a little bit different. But I just find that I have more control of how much fluid I'm giving and to what patient. And you know, no matter how much you prehydrate, I always find it's not adequate when you actually check a right heart. I leave the right heart in, clamp it off, and then use it for the opening and closing wedge, unless I'm doing a high-risk case. And it's amazing. Sometimes you give 1 liter, 2 liters of normal saline to get adequate filling before you start a case. It's well worth it for the kidneys. That's how I do it.
That's awesome. Manos?
Maybe one second question for Dr. Schwartz. I think we're very relieved to hear that our profession is not at risk quite yet. But the question comes, should the intervention be more involved in the referral of patients? For example, ACS patient on a TORVA 80, LDL is 90. Would you send him directly for evaluation for PCSK9? What is the pathway, at least in your institution, and being a leader in the field?
I think we still need more data to make that recommendation. We'll know more about the efficacy in ACS when the trial that's specifically targeting that population is completed. You know, I think the cost-benefit analysis is still wanting, and I think that's reflected in the lower than expected uptake of these agents in practice. Now that may change if and when the small interfering RNA approach to treatment with PCSK9 inhibition becomes available. In that, you know, the cost of producing a small interfering RNA is much, much less than the cost of producing a monoclonal. And secondly, these drugs probably will have to be given only twice a year to maintain low levels, one subcutaneous injection of 1 milliliter twice a year. So I think that may change the landscape. But for now, I think the benefit probably is related to how high the initial LDL levels are. We haven't seen those analyses, those detailed analyses from Fourier yet. But you know, I think if someone had an LDL on statin therapy that was well into the mid-100s, then I think that the return on investment would probably be worthwhile. But again, we need more data to be in order to be more precise about those kinds of statements and recommendations.
Okay, that's great. I mean, that's a great discussion, and I think there's still a lot of questions, but we have to move to the next session.